topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we'll gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@CAHN.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning, nice to see you all again, and thank you for giving up your time and joining us to this morning's health hour. My name is Ngozi Ediosage. I'm a neonatologist and I work in Manchester, and I also support the Caribbean African Health Network with some of their health hours. I am delighted and consider it a great privilege to introduce today's speaker, who is Dr. Mercy Ochuko-Emore. She is a consultant psychiatrist, but she also specializes in old age psychiatry. Now, aging is inevitable, and as part of aging, for some people, that will be accompanied by dementia. It's something that worries quite a lot of us because we might be worried about getting it ourselves, but we also might have family members who are already showing signs of dementia. Now, culturally, in the Black community, sometimes it's been approached with a lot of fear. However, there are resources out there to help you, and that's what this session will explore, try and take out some of those myths. So welcome to today's health hour. Please get involved, put your questions in the chat. As if you've joined us before, you will know that the session runs with our experts telling us about the condition, and then you have the opportunity to ask questions directly of the expert, which I can do for you. So thank you very much, Mercy, for coming today. I'm really looking forward to your session because I'm getting older, so as we all are. So thank you.
Thank you, Ngozi. Just making sure I'm sharing my screen. Just give me a second. Okay, I'm back on. Good morning, everyone. Can you hear me? Ngozi, you can hear me?
Yes, we can. I can hear you well.
Okay, thank you so much. Thank you for having me on. It's always a privilege to be able to talk about dementia, and I'm glad I'm able to do this again for the second time. I'm Mercy Ochuko-Emore, like Ngozi said. I'm a consultant, old age psychiatrist, and I work with the Norfolk and Suffolk NHS Trust. My day-to-day job involves assessing people, making diagnosis of dementia, and also offering treatment to my patient and their carers. And because dementia is an ongoing illness, so there's a need for having that ongoing support. Today, I'll be talking about how to assess, diagnosis, and also management of the condition. So the purpose of this talk today for me is to raise awareness of dementia within the Black community. Like the moderator said, we're all aging, and the Black community is increasingly having aging people, because compared to the white population, years ago, there were more younger Black people compared to the white population, but now we now have an aging Black population in the UK. So it's a subject that we need to continue to talk about, because there is support out there for people in terms of having a diagnosis and also support with care. I will encourage people, if they have any concern regarding their memory, to access services. And that could be via their general practitioners, GP in the UK, and their doctors in other countries, if you have any concern regarding your memory or that of a loved one. I'll also talk about the things we can do to reduce our risk of developing dementia. And these tend to start in midlife. So you don't wait till you get old to start putting in place things that can reduce your risk of developing the illness. I will also talk about treatment options and other help available. Dementia is an illness that is caused by damage to the brain, and it will affect some brain function. The most common one is memory, which most people recognize. So short-term memory loss, especially. They might have problem with language, the ability to communicate, getting stuck in the middle of conversation. They might struggle with learning, especially new learning. If they have any new gadget they have to learn about, or any new document they need to learn, that becomes more challenging. Their ability to plan might not be as good as it used to be, neither with their ability to execute those plans. Their judgment might sometimes be affected. So is their personality. These changes usually start to impact on daily life, because we're all forgetful to some extent. We all forget things now and then. But in cases of dementia, it's the frequency of the forgetfulness that matters. It will affect their daily life, their ability to look after themselves as well as they used to. It might affect their ability to do their job, especially if they are younger and still in employment. It might also affect their ability to interact with other people properly. Dementia as an illness is usually progressive in nature. It's an illness for the elderly, we usually say, but sometimes younger people can be affected. In 2021, it was estimated that over 1 million people are living with dementia in the UK. Of that number, about 42,000 of them are under the age of 65 years. Around 25,000 of this number are from the Black and ethnic minority group. Just to be clear, this also includes the Asians in that main group. So about 25,000 are from that group. And it's expected that that number will rise significantly, especially given that that community are beginning to age in this country. So looking at the picture for the African Caribbean group in the UK, a kind of national study was done and published recently that looked at over 600,000 case record from 1997 to 2018. And it showed that the rate of dementia is 22% higher among Blacks in the UK compared to the white population. Blacks are also more likely to be diagnosed at a much younger age. And I think part of the reason for this is because of cardiovascular risk factors, which are a bit higher among the Black population, the risk of hypertension and diabetes, and that in turn increase your risk of developing things like vascular dementia and also Alzheimer's dementia. Not surprisingly, African and Caribbean people are usually diagnosed at a later stage of the illness. And I think partly because people often mistake the early symptoms of dementia with normal aging, so they don't seek help on time. So what are the symptoms of dementia? The most common one that we know about is memory loss. And this is usually short-term memory loss. You will have a conversation with people and they forget that the conversation has taken place. They sometimes will swear blind that you didn't have that conversation with them. You might have plans to go out or plans to do things, and when you turn up, they might not be ready because they can't remember. they sometimes will repeat themselves. They will tell you the same story over and over again during the course of the day. They might also ask you different questions. I saw a video recently trying to promote dementia within a community of the mother calling the son several times within a few hours to say, what time are you coming to take me to church? What time are you coming to take me to church? And that again send the alarm bells that something might be wrong. So when people are asking you the same question several times during the course of the day, it's worth checking out those symptoms. They might put things away and can't remember where they've kept them. They might put things in the wrong cupboard in the kitchen. They might put things in wrong places. Things that are made to go in the fridge might end up in the cupboard, and vice versa. They might have difficulty in understanding conversation they're having with people. We all do get distracted from time to time, but they get easily distracted and might forget to turn things like the cooker off or turn taps on. They might struggle to multitask, that doing two things at the same time might become a difficulty for them. They sometimes might forget to take their medication or not sure if they've taken it or not at all. That might lead to them taking too many or not taking enough. They sometimes get confused about the time of the day. I know when you're not in employment, it is difficult to keep track of the day sometimes, but you will notice the changes. You will notice that they're becoming increasingly confused. They might start calling at an unusual time of the day. People sometimes get confused with regard to their environments. In the early stages of the illness, people are still conscious of where they live. But as it progresses, especially at the advanced stages, people might get increasingly muddled. They might not recognize their own home. The home they think is theirs might be where they grew up, might be their childhood home. When you ask them for their address, that might be the address they're providing for you. So those are some of the symptoms that can result because of memory loss. But some of this is usually at the end stage. And just need to emphasize, not all patients experience all the symptoms. In some cases, symptoms might be more prominent than others. Another symptom is difficulty with carrying out tasks. Things they were able to do before easily, they now start struggling. With the cooking process, they might not be sure of what ingredient they've added, what they need to do. Like I said earlier, they might forget to turn off the cooker. They might struggle with the timing for their cooking. They might struggle with basic things like the remote control. You see people calling their loved ones to say the television is not working because they can use the television remote control. Or sometimes they might misidentify the phone, trying to use the phone as the TV remote control. They might struggle with using the phone. Initially might be doing complex things on the phone, but as that progresses, even things like text messages might become a challenge for them. Microwave, oven, washing machine, they will struggle with sometimes, especially if their old ones have been replaced and the new one, they have to learn how to use it, then the difficulty becomes more obvious. Language is for some patients might be a problem. In some type of dementia, is more obvious than other type. They might struggle when they're having conversation. I know we all do get stuck sometimes, but in people with dementia, the frequency increases. They might struggle with forming the right words, making the sentences, getting stuck, and that might lead to isolation. So when they're in a group, they might not participate as much because they don't want those difficulties to be obvious. They don't want to get stared at because they can't finish their sentence. They sometimes might forget what objects are called. I know we all do that. You want to say, oh, that thing over there. So there will be a lot of that thing over there or something instead of getting the right words. Difficulty with recognizing people an object is one of the symptoms of dementia. At the initial stages, it might be people they don't see often. So maybe people they've not interacted with for some time, they will struggle with. But as the illness progresses, that even start include family members, maybe their children, the grandchildren, they will start having difficulty recognizing them and remembering who they are in relation to them. Towards the end of the illness, they sometimes struggle to recognize themselves. They look at the mirror and can recognize the person they're seeing, and we normally call that a mirror sign, but this is in very advanced cases. Other than those 4 major symptoms of dementia, we have other symptoms that people with dementia can experience. And one of them includes depression. That tends to be common in people with vascular dementia, especially at the early stages, because they have some insight, knowing that they know that something is not quite right. So that tends to affect their mood and they become depressed. People can get agitated because they don't understand what is going on around them, and that might lead to aggression sometimes. You might have a change in behavior, you might have a change in personality because of the illness. People can sometimes see things that are not there that other people can see, and they can also hear voices that others can hear. Seeing things that others can see is particularly common in a type of dementia we call Parkinson's disease dementia or Lewy body dementia. That is one of their main symptoms. People might wander out of their home because they don't recognize their home. They don't recognize it as their home, or they are out looking for their children who are already grown up, or they are looking for maybe dead relative. If they've lost their spouse, they might go out wandering, looking for them at inappropriate time of the day. Sometimes they are not appropriately dressed for the weather. So that's a major risk we look at towards the end of the illness. People might become very suspicious of other people's intention towards them. They develop paranoia. They don't know. They usually will say, oh, people are stealing their things when they've misplaced it and can remember that they did. They might accuse people of having a bad intention towards them. So those are some of those things that can happen with people with dementia. And some of those symptoms, like the paranoia, might predate the memory loss. So people can start exhibiting some of those symptoms before the memory loss becomes very evident. So what are the types of dementia? Often, a lot of patients and their loved ones will ask me, what is the difference between Alzheimer's disease and dementia? Alzheimer's disease is a type of dementia. It's the most common type and is more in women. About half of the cases of dementia is due to Alzheimer's disease. The second most common type of dementia is vascular dementia. Unfortunately, research has shown that that is more common in Blacks, and that is mainly due to what we call cardiovascular risk factors, such as diabetes, high blood pressure. Those all contribute, and stroke, those all contribute to vascular dementia. Parkinson's disease dementia is a type of dementia that is seen in people with Parkinson's disease. We also have Lewy body dementia, which is from that family. So they are all from the same family, the Parkinson's disease dementia and Lewy body dementia. But people who have a diagnosis of Parkinson's disease before they develop dementia, we'll call that a Parkinson's disease dementia. Some people might have dementia before they start having the mobility problem of Parkinson's, and we call that a Lewy body dementia. The fourth most common type of dementia is frontotemporal dementia. That tends to occur more in younger people. Then we have other rare type of dementia, which I will not be discussing today. So what are the risk factors? What are the things that will predispose us to develop dementia? The most common one, which unfortunately we can't do anything about, is aging. The reason most people would develop dementia is because of age. That's the biggest risk factor, that the older you get, the more your chances of developing dementia. So for example, if people around the age of 65 years, just about 1% might develop dementia, but that increased to almost 30% when you get to 80. So the older you get, the more your risk of developing dementia. Another of the risk factor is your gender. Women are more likely for Alzheimer's dementia and men for vascular dementia. Your level of education also will help reduce your risk of dementia. Those with a good level of education, they are protected to some degree from developing dementia compared to those with very low education. In some type of dementia, there is genetic factors contributing. There is some hereditary aspect to it, especially Alzheimer's dementia. In some cases of Alzheimer's dementia that occurs before the age of 65 years. In those group of people, they have a chance, there is a 50% chance if they have the gene of developing dementia. That is for those whose family member have developed it before the age of 65 years. After the age of 65 years, which we regard as late onset, your chances of developing it is only about 2 to 3% compared to the general population. Cardiovascular risk factor, there are risk factors both for Alzheimer's and also vascular dementia, and that include high blood pressure. So it's very important that we pay attention to our blood pressures, because not just stroke that comes from that, you also have dementia, cardiac problems. So there's a lot of things associated with blood pressure. That also includes diabetes. Then we have obesity. We need to, healthy living is now the key, that you need to remain physically active. Smoking, we advise, and I'm sure all of you would have gotten an advice from your doctor at some point in time, if you're smoking, to stop smoking because of the associated risk. Also things like stroke, anything you can do to reduce your risk of stroke will also help, because it is a risk factor for dementia, especially vascular dementia. Other things that can increase your risk of developing dementia is depression in midlife. So when you develop depression in midlife, it increases your risk of dementia in old age. Head injury also is a risk factor for some type of dementia, like Alzheimer's. Like I said at the beginning of this talk, it is important we put things in place from midlife to reduce our risk of developing dementia. But I will emphasize that there is, any time is a good time, but it's best when you do it in midlife. But it's always better late than never. So we can all do something at any time. Having a balanced diet is important. Having a diet that is rich in oily fish, that's important, nuts, fruits, vegetables. So having a balanced diet is important, not just for dementia, but for a lot of things. We also, as people, we call it brain stimulating activities. We say you either use it or you lose it. So things you can do to keep your brain active. Crossword, jigsaw puzzles, Scrabble, any brain activities is very important, and that should be something that you incorporate into your daily activities. Blood pressure cannot be overemphasized in the Black community because it's quite common. So it's important, if you're hypertensive, to make sure that you're taking your medication regularly and that your blood pressure is well controlled. And this will not just reduce the risk of dementia, it will reduce the risk of stroke and many other conditions. We need to keep active, live an active life. Like I say to people, I'm not telling you to train for the Olympics, but do anything that you can to keep yourself active. Just keep moving. Do something that you're comfortable doing. So we need to keep an active lifestyle. If you enjoy running, do that. If you enjoy going for a walk, anything to keep you physically active, we massively encourage. Diabetes is another illness that affects our community a lot. If you are diabetic, make sure that you're taking your medication, make sure that your blood sugar is well controlled, make sure that you're sticking to the advice with regards to the diet you should be having to help maintain your blood sugar. And also make time to relax, because that is also good for the brain. It gives you time to catch up. So it's good to find time to relax in the midst of all our busy life. Find time to relax because it's healthy for your brain. So with dementia, early diagnosis is key. If you have any concern about your memory or that of a loved one, you should see your doctor. Your doctor will usually have a discussion with you or the family. They might do a short memory test at your GP surgery. They might do some blood tests to just rule out other illnesses that might mimic dementia, because we have other physical illnesses that might look like dementia, but it's not dementia. So we do some of these blood tests to rule that out. We do a brain scan. Your GP might request for the brain scan or wait for a specialist to request for that. If from the conversation you have with your GP and the blood test, they might send you to a memory clinic to have a specialist assessment. The health condition, other health condition the GP will want to rule out that mimic dementia will include shortage of blood, anemia. This might be due to low blood iron, folate, or vitamin B12. Your GP will want to make sure that those are all within range. They can also check your thyroid level to make sure that is okay, because low thyroid level might affect people's memory. They will check what we call your blood calcium, just to make sure that that is okay. We make sure there is no infection. We make sure that it's not due to depression, you forgetting things, because people who are depressed sometimes don't take in information and they present as if they have symptoms of dementia, and we call that pseudo dementia. It looks like dementia, but it's not dementia. So your GP will want to rule out that your presentation is not as a result of depression. People might have problem with their hearing. As we are getting older, people sometimes struggle with their hearing. And sometimes that forgetfulness, their inability to recall information, is because they've not heard it in the first place. So it's always worth checking that the hearing is okay. It's also worth checking that there is no problem with the eyes, that your eyesight is as good as it can be for your age. So if the GP kind of rule out some of all these illnesses and think that there is still a concern, then they will refer you to the specialist. Earlier, I did mention that within a community that we tend to be diagnosed at a later stage. And some of the reasons that research has shown that have contributed to that is lack of awareness within a community, and the belief that it is due to normal aging. So people don't seek help on time. Therefore, it tends to present when there is a crisis. Another reason why people don't go and see the doctor is the stigma associated with it, that they don't want to be classified as having an illness such as dementia. And in some cases, because they are being seen in the mental health service, people from all cultural backgrounds do have that fear of the stigma associated with mental health. So they might not want to see the doctor. But we encourage everybody that early diagnosis is key. See your doctor if you're concerned, because there is support out there. There is treatment for some form of dementia, and the earlier, the better. Another reason why people don't see the doctor when they are worried about the memory is fear of being put in a care home. And I hear this all the time from my patients. They don't want to go into a home. They want to stay in their own home. Having a diagnosis of dementia does not equate to going to a care home. People live well with dementia in their own home with the right support. People are also worried that there are no treatments available. Therefore, there is no point seeing the doctor. We do have treatment, and the treatment will not necessarily be medication. There are other forms of support, which is also a form of treatment for people with dementia. So we will encourage people massively to see their doctor if they have any concern regarding their memory or that of their loved ones. The medication we have for dementia, not a lot, just 4 tablets we have. And this is mainly for Alzheimer's dementia and people that have a combination of Alzheimer's and vascular dementia. There's also one of them is also for people with kind of Parkinson's dementia. And they are available from the specialist clinic. In some places, they will ask your GP to prescribe. In other places, the specialist clinic might give you the medication for a few months and monitor it before transferring that responsibility to your GP. So there are medication. It's not a cure, like I say to all my patients, but it does slow down the rate of progression. Alzheimer's is a progressive illness, but this medication can help slow down the rate of that progression. There is social support available. By law, if you have a diagnosis of dementia, you are eligible for what we call a care needs assessment. So a referral can be made to social service. I know people are sometimes worried about being referred to social service. A referral can be made to social service, and you will have the social worker have a conversation with you regarding what your care needs are. At the early stage of the illness, people are still able to meet their needs most times with minimal support. But it's always worth having that care needs assessment. So should you need it in future, they already know about you. So it's having that care needs assessment to identify what your needs are and how best those needs can be met. You are also will be eligible for a carer's assessment if you have any loved one supporting you at home. Depending on the hours of support they provide for you, they are eligible for carer's assessment. You can have some home care to support you in your own home, especially those without any family who can provide the intensity of support that we need. You can have daycare, which is good, not just for the interaction with other people, but also to learn and share experience. There's respite care, should you need that, that will be available in some locally, in some county more than others, but there's always room for respite care. There's befriending service. This might vary across the country, but in some local authority, they have those befriending service to help people in their own home to spend time with them. Attendance allowance is one of the few allowances that is not means tested. It does not depend on how much you have in your bank account. But if you have a diagnosis of dementia, you are eligible for attendance allowance. So it's always worth requesting for that application. I know it can be difficult filling some application forms in, but you can have help from Age UK with those forms. So apply for those attendance allowance because it might come handy later. There are other things, like I said, people do live well with dementia in their own home. We have things we call assistive technology to help support people in their own home. And that includes a dementia clock, which I've shown an example there on the slide that will tell people about the day, the time of the day. Some will tell you about the weather. And I know Alexa is also helping some people with some of those difficulties. So you have the dementia clock to kind of orient people within their own home in terms of what time of the day, especially during the winter month, when it becomes dark very easily. You find people going to bed quite early, not realizing the time of the day. So the dementia orientation clock. If you have people who have memory problem, is worth having in their own home. As we are getting older, our medications sometimes increase. You start by taking one tablet and that quickly increase to 3, 4, or 5. So sometimes people get muddled, especially when their memory is not as good as it used to be. So we encourage people to have medication boxes, to kind of have the medication set up for the week. And it's also easy if they are not taking their medication. If a family member visits, it's easy to know that the Sunday medication have not been taken, the Tuesday one have not been taken, and we are on Saturday already. So it is worth having those little things to support people in their own home, and also to promote their own independence, that they are able to monitor that, they are able to administer their medication with some assistance. We have things like pendant alarm for people who are prone to falls. Some type of dementia, like Parkinson's disease dementia or Lewy body dementia, one of the symptoms they can have is repeated falls. And we have situations when people live alone in their own home, they can have a fall and they won't have any contact to the next carer visit or until the family can reach them. So having those pendant alarm, you can either have them on your wrist or you can wear them around your neck, so that if there is any need to call for help, that you can easily press on those buttons and help will come your way. There are also sensors mats that people can leave when you get to a case where people start wandering or living at inappropriate time of the night, that those sensor mats that can detect if they've left home or not, and they will raise the alarm. We also have hydration cups that encourage people to drink. There are GPS that they put in key rings, so that when people are leaving, you kind of set a safe zone, so that when they're leaving that safe zone, the alarm goes off. So there's so many gadgets that can be put in place to support people with dementia in their own home. The other things you need to know about with dementia is some legal stuff which we call a lasting power of attorney. If there is concern about your memory and you still have the ability to choose the person you want to help you, should you get to a position where you're no longer to make decision, then you can choose someone who call the attorney. And that can cover finances, that should I get to a stage when I'm no longer able to manage my finances, I want this person to help me manage it in my best interest. You can also have for welfare and health. These are usually legal documents. They are registered with the office we call the Office of Public Guardian, and is a criminal offense if somebody misuse their position as your attorney, because at that time you'll be deemed as a vulnerable person. So there is a protection for people. So it's worth having it, because if you don't have a lasting power of attorney and decision needs to be made regarding your health at a later stage, that will be made by the clinical team. There's a cut of protection for people who have lost their ability. So if you have a loved one who has like an advanced dementia and can no longer choose the person they want to manage their finances, you will have to apply to what we call for the cut of protection to give you that authority to manage the person's finances. Because if something happened, you just cannot walk to the bank to say, oh, I want to withdraw this money of my mom because she's no longer able to do it. There must be some legal backing to that. And I know other than lasting power of attorney and court of protection, sometimes people are registered as a third party in bank account of their loved ones so that they can help manage their finances should they need to. Earlier, I did mention that dementia is a progressive illness. So the need for advanced planning is very important. You know what you want, you know how you want your things to be done. So we will say to people, now that you're still able to make those decisions, it's best to put things in place, advance plan your care, how you want things to be done for you in future. So that's quite important. I know writing will is not something we do a lot within our community, but that will also be included in this aspect, that aging is inevitable and we'll all probably need a will at some point. So we will encourage people as part of advanced planning for your care to also think of making a will, especially if you're having signs of memory problem, because when the illness is advanced, you will no longer have the capacity to make that. So advanced planning is quite important in cases of dementia. There are help available from different charity organizations. There's Culture Dementia UK, and I'm just including their telephone number there. There's Alzheimer's Society, there's Age UK, there's Dementia UK, there's also Carers UK, and you can also check your local council website for more information. So there's information out there with regarding support for people with dementia. Dementia is a conversation that needs to be ongoing within our community, not just to raise awareness, but also to ensure that people get the diagnosis and the support in a timely manner. Thank you. I'm sure I'll finish a bit early.
Thank you. That was perfect timing, Mercy.
Thank you.
Because we've had quite a number of questions, and so that gives us enough time to answer some of those questions. Thank you so much. That was fascinating, and for lots of people who are here today, they have concerns and some questions about dementia, which is great. So I'm going to this. So one of the questions we've had is, someone said that they came across a lady who was 35 having early dementia, and they wanted to know how true could that be?
Yeah, personally, I've had a patient, my youngest patient so far has been 38 years. So there is a possibility that that is very true. And this was a patient, is the one who have an hereditary form, but the youngest patient I've had as a clinician was 38 years.
Gosh. And one of the things that struck me when you were talking was that you said there were about 42,000 people, but 25,000 of those were babes. So that means that it affects us more than the prevalent population.
No, the 25,000 for BAME, it's from the 1 million.
Okay.
And that includes both the Black and Asian. That's why I specified that includes both the Black and Asian. The 42,000 of that 1 million are the under 65.
Okay.
That will include those 35 and 38-year-old.
Gosh, so it's actually much wider spread than we think. Actually.
Yes.
Yeah. Now, one of the other things that we've got here, we've got a question here that says that, is it helpful for people with dementia to attend support clubs outside their home?
I think so.
And why is that? How does that help?
For the social benefit too, because with dementia, you can be very isolated. And sometimes you think all the problem you're experiencing are just down to you. And so we do encourage those day center and support group, because sometimes learning from other people's experience or things are managed. Like I always say, some of this management, there are no textbook way about how to deal with the situation. Because when people are repeating themselves, people might ask, how do I manage that? And you might learn from other people's approach in the group. I give a typical example sometimes to my trainee. With people with Parkinson's disease, they tend to see things that others can see, and it can lead to difficulties. And I had a patient once whose wife said, your eyesight is definitely better than mine, so you can see things better, and that works for them. So hearing other people's view can be helpful in such group.
Okay, thank you. I'm just going to ask if you can stop sharing your screen actually, because you finished the slide so we can see more of you. And
I'm coming. That's where the problem
fine.
is going to come now. Yeah, thank
Great.
you.
Yeah. What the other thing that someone's asked is about leaflets for the community.
Yes.
For people in the community to have things where they can access additional information. Is that widely available, or particular websites?
Well, there are leaflets usually from each hospital, like in my hospital, there are leaflets that target the different type of dementia, which we normally give to people at the point of diagnosis. And they do have a leaflet from Alzheimer's Society. They do a lot of that, and they have a lot of information online in terms of the symptoms and how to manage some of those symptoms.
Okay. Now, one question we've got here is, when should someone start thinking about getting someone to support them with the lasting power of attorney?
You can do that at any point in time. There is no, even people as young as in their 30s, and that you can get an LPA in place. For the finances, people can support you even when you still have capacity if you want them to. But for the health and welfare, you must be deemed to have lacked capacity for that to become effective. So as long as you can make decision regarding your health, even when you have an attorney, they cannot make that decision for you. So it's only when you've lost your ability, but you can do that at any point in life. But I always say the earlier, the better, because you never know what's around the corner.
Okay. You know, when you started talking and you had all those symptoms, and this is not to minimize it for people who have dementia, but I looked through all those and I thought, yeah, that's me, you know. So how can you differentiate just normal aging and dementia?
Okay,
So,
like I said earlier.
So if there's someone here that you think, yeah, I've got all that, because I know these sessions are supposed to raise awareness and not raise anxiety.
Yes.
But just for anybody that was like me, thinking, yeah, that's me, and then you went on to say that we don't diagnose it early enough. Yes. So before we have a whole host of people going off to their GP on Monday.
I know. Thanks to me.
So which ones? What is the real differentiating factor? Okay,
like I said earlier, all the symptoms that we mentioned, we all experience that, but it's the frequency. Okay, that's one of the key. That we all have walked into a room and wonder why we're here. That's something that happened to people, but it starts happening on a regular basis, and it start impacting on your ability to function. So what we say, the definition of dementia is, one, you have all those problems, that's one. Then two, for things like Alzheimer's, your GP will expect your symptoms to have been there for us to be quite clear with about the diagnosis. The symptoms should have been ongoing for about 6 months for Alzheimer's dementia, and it should be bad enough to interfere with your ability to function.
Okay.
So for example, going for a school run, forgetting to pick the kids, but not just a one-off, you're doing it more often, or forgetting to do things, or you might have an appointment with somebody, you won't be there on time because you've forgotten about it. So it's the frequency of that we now look at.
So who comes to see you? Because you're an older psychiatrist that specializes in dementia, and who goes to see the GP? So what sorts of cases do the GP say, well, I can't manage that? Because I would have thought that dementia is so common that the GPs would manage that.
At the moment, most of the diagnoses of dementia are made by older psychiatrists in the UK. In so many other European countries and other parts of the world, they're made by neurologists too. So both us, the neurologist and geriatric physician, can make the diagnosis. Most GP, because it will involve an extensive assessment, it's not a 10-15 minutes slot at most GP. So usually for my patient, we're looking at a minimum of 1 hour for that consultation. Okay. So there is an extensive assessment process. So that we have, when they start having those symptoms, they go to their GP. Like I said, they will do those basic blood tests to just rule out that it's no other health condition that is mimicking dementia, or it's not due to depression, and then they will refer to us. So I see everybody who has memory problem, whether they're in their 40s, their 30s, or in their 90s. So once they have a memory problem, they come to all the psychiatrists.
Well, that's good to know, so that the diagnosis is based on some real evidence. Yeah, so it's not that we can just bandy these words around. That's great. Someone's asked about Admiral nurses, and thanks for that goal. I haven't heard of that before, and you might have. Is it something to support dementia patients? So it says, what's their area of scope, and are they available nationwide, or is this another postcode lottery?
I think it's a postcode lottery, because not everybody, even in my catchment area, I work in Suffolk, Waveney aspect of Suffolk, and in some part of Suffolk, they have more support from the Admiral nurses compared to other parts.
So for those of us that haven't heard of this before, what is an Admiral nurse?
Oh, I think they are nurses who support people with dementia, not just dementia, with many other health conditions in their own home.
Okay.
We don't have any in our team, but there's some aspects of council, Suffolk Council, that do have Admiral nurses, but we don't have any in our team.
You mentioned about medication, and there's been a question here in the chat that says, thank you, Dr. Diana. It says, how do the medicines actually work, and to reduce progression of dementia? Because some people think it's inevitable, and how can carers tell that the medicine's actually working, whether they're helpful or not? Okay, all right. Like I said, it's a progressive illness, and the medicine only slows down the rate of progression. With dementia, there are some of the chemicals in the brain, one of them, which we call acetylcholine, that is reduced. So one of those medications, 3 of those medications, they're just 4 medications, 3 of them are from the same group. So those are the cholinesterase inhibitor, and one of them is from a different group. So what they do, they kind of help reduce the breakdown of those chemicals and increase the level of the chemical, which we call acetylcholine, that helps with memory in the brain. And that's how it helps to reduce the rate of progression of the illness. The progression varies from one individual to another. It's usually what we say, some people might have other health conditions that will make their progression faster than other people. And usually it's the little things, their ability to look after themselves a bit more, their ability to recall information a bit more, their ability to get less agitated in unfamiliar environments. So those are the little subtle changes. And when you do their assessment, their screening tutor, you're not seeing the deterioration massively in their score, like you might see for people who are not on the medication. And just to be clear, not everybody will benefit like with every medication, but majority from research have benefited from it. Okay. Now, Norfolk and Norwich doesn't strike me as a very diverse area.
Oh, no, it's not.
However, so this would probably be from what you hear from colleagues. Are there any specific things that, as dementia in the Black community, that there are specific supports? Because I remember in Manchester, they used to have I think they still have it, the Afro-Caribbean Care Group, which means that you would go to a care setting on a daily basis where you'd get your food, listen to your music. And I felt really that would help. Is that another postcode lottery? And do you think that things like that would help, especially as there are more and more older people from Black backgrounds? I would like to see a care centre for me when I get old, for people from the Nigerian backgrounds. I can have my eba
and jollof rice.
And jollof rice.
Yeah. Norfolk and Suffolk is not a very diverse area, and I've worked as a consultant now for over 12 years, and I've only had a Black patient in that 12 years, just one. So it's not an area where you have a lot of people from the BAME community. And if I even include Asians, I've not had more than 5 patients in the last 12 years. That is for Norfolk and Suffolk. I work in Suffolk, so I'm speaking for Suffolk in the area, Waveney area, where I cover. So we don't have that. So this is mainly from people in the London area, Manchester, big city, when you have the big BAME community. So they're doing a lot for this group there. In this area, they won't have a lot of that focus because we don't have a huge BAME population. And even the BAME population we have at this point in time is a much younger group. So we don't have those difficulties.
Okay. And you can clarify this. I used to worry, and I think there's a question in the chat about this as well, about how you do the assessment. So if you're going to assess people by asking them, when did the Second World War finish? Well, what was who was the main character in Only Fools and Horses, or things like that that are not culturally appropriate for us? Is that, or is it much more? Is it much wider than that? How you assess it? Because memory things, the memory questions I've heard are not our memory.
Yeah, you're right about that, and not just for us, for even other people from the BAME group in general, not just the Black community. And I do the assessment mainly from history and what we call a cognitive testing process. The history is a key, and with psychiatry, the devil is in the details. So the history is a key for us. But the assessment tools we have, I would say 100% they are not culturally appropriate. I've had the chance of assessing someone from a BAME community once, and I had to modify some of those questions because there is no way. For example, when you're looking at language, you ask somebody, what is a marsupial, which is a kangaroo. That doesn't work for us.
No,
or when they show you a kangaroo, there's so many people from the BAME community who might not know what a kangaroo is. Or some of the question in terms of memory would be, when was looking at the Edinburgh Cognitive Examination tool, which we use, we ask, what's the name of the President of the United States? For the people from my community, that might not be relevant. Or when the president, or which of the president of the United States was assassinated in the 1960s. Again, that is not relevant for my group. Even for a younger generation, that might not be relevant. They might know the founder of Facebook, but they might not know the president of the United States that was assassinated in the 1960s. So some of those questions, when I've had to assess someone from a BAME community, I've had to modify that. I've had to modify some of those questions. And just to point out that when dementia starts advancing, in some cases, people reverse to their first language. So they will stop. They've been speaking English fluently for many years all their life, but they might revert to their first language. And some of those questions, not just if you're not from the English speaking world, might not be appropriate. I've had an Italian patient who is married to an Englishman with her children raised in this country. Now we need an interpreter to be able to assess her because neither her children nor the husband can speak Italian, and she's reversed back fully to Italian.
Okay. I hope one of your questions isn't who is the current prime minister, because that will confuse many people.
I know that is one of our questions, and that's the difficulty you are having now because we've had a lot of changes.
Yeah, we have a lot of changes.
Okay.
There's a question here from about, I'll just read it out. My father was initially diagnosed with blepharospasm. Later on, they realized it was a side effect of Parkinson's. Is this common? And are there any other known side effects of dementia?
When she said a side effect of Parkinson's, or it was a symptom of Parkinson's?
Well, they put it, I read the question out as read.
Yeah.
And sometimes I try and interpret, but dementia is not an area of my expertise.
Yeah. So people we have with Parkinson's disease, that we have the cognitive symptoms, and we have what we call the motor symptoms, and some of their symptoms varies from problem with mobility to problem with changing their tone of voice. People with Parkinson's, as the illness advances, their speech becomes very soft. So they have all sorts of symptoms, from constipation to many other symptoms. And that could be one of those symptoms of Parkinson's. But I don't make the initial diagnosis of Parkinson's. That's left for the neurologist to make. But when they start developing memory problem, they come to me. So I make the diagnosis of the dementia in Parkinson's disease.
Okay. There's another question here, and thank you very much to CAHN. They have sent a web link about dementia advice and guidance, and they've got some videos, because there was a question from somebody else about how to support family members with dementia. What was the best way of doing that? Any specific help that family members can access to help with the behavioral and psychological symptoms of dementia? And CAHN has very helpfully given a link, and it's called www.culturalappropriateresources.com. So thank you for that. CAHN team, if you can just copy that link, and when we send out the slides, we can include that as well. Someone's asked about the best culturally congruent tool to assess memory, if there's any that you know of that is evidence-based.
Well, I know they're trying to explore some in the SODOC area, but because I don't really use that, I don't cover that population base, I'm not familiar with any specific tools, but there will be some available. And I think some are also being developed, because we've realized that those memory screening questions, they are not appropriate for our culture and might not be able to pick out any significant problem. But like I said earlier, the diagnosis, the history is the key.
Okay. Obviously, in this group of patients, incontinences can be a problem, especially urinary incontinence. Is there a concern that some of the medication that we use to manage dementia can actually make incontinence or an overactive bladder even worse?
Yes, there is. Some of the medication, the side effect, things like donepezil, urinary incontinence is some of the side effect of those medication. And also people with Parkinson's, from what I've experienced, I've getting a few of my patients coming now with incontinence, especially at nighttime incontinence. So some might be due to the medication, and some might be secondary to the condition, especially things like Parkinson's disease.
And the questions here from family members, I think, about appropriateness of where to care for relatives. So there's a question here about, if you have a patient who's about 60 and has dementia and now has depression, is it better that she's in long-term care, I presume, here in the UK, or is it better that she's actually taken back to Nigeria to stay with her family to see if she can heal?
Well, there is no cure for dementia. So the healing aspect, in terms of there will not be an improvement cognitively to the stage where the person is able to function. Like what we say, if you recover from dementia, that means the diagnosis is wrong in the first place, because it's not an illness that do have a cure. And I think the person should be supported in the place that they will most likely be able to get all the adequate and necessary support to keep them going. We normally encourage living well with dementia. Having dementia is not a death sentence. There's still a lot that those people can do for themselves, and you encourage them to do the things they are able to do themselves. So you enable them to be able to do those things they are still able to do. In terms of specific between caring for them here or caring for them in Nigeria, it will depend on the resources available and how best that person can be supported.
Yeah, okay. And there's somebody called iPhone, so I don't know who it is, who's got their hand up. Did you want to make a comment or ask a question?
Good morning, my name is Gloria. Sorry, I didn't actually put my name. So basically, I'm just a bit curious, because I've been on sleeping therapy for like 3 years now. So lately, my GP has refused to prescribe it, which is Zopiclone. So the reason why she has refused, she said, I can develop an early dementia, which is loss of memory. But I was thinking she's just lying, that, oh, she doesn't want to prescribe it and all that. So now that she just mentioned it, I wanted to find out, is she telling the truth, or she's just trying to push me out of the way from prescribing it?
Well, I'm sure.
Thank you, Gloria. That's an interesting question.
Yeah, I'm sure most GP, we are not advised to prescribe those sleeping tablets for long term. They're meant to be short-term medication, and they will kind of advise on sleep hygiene and other things you can help to promote your sleep rather than medication. All medication do have side effects, even including paracetamol, but we don't have that specific to say if you take Zopiclone, you will develop dementia. Not that I'm aware of, but are we want to agree with the GP that it is best not to have the medication long term.
Thank you. Okay, so just a few more minutes now. There's just a couple of questions which I think I'm going to ask because I think they're important. So one of them is that, and I think we've been really lucky today because we've had patients or members of the public who have joined, but I think we've also had some experts as well who've been able to share their expertise via the chat. So this is the question that says that in many South Asian and Chinese languages, there is no word or term for dementia. Can you share with us what your experience is in the situation regarding African languages?
Well, not that I'm aware of. Like I know when I had this presentation, initially one of my co-presenters there who's doing some charity work on dementia in Nigeria did mention that there is no word for that. Most people use different words like they've become children again, or it's caused by witches, it's caused by evil spirit, or the bad things that you've done in your previous life. That's what is making you forgetful. Again, it's lack of the awareness that this is an illness. And previously, people didn't used to live long enough to develop the illness. So it wasn't something that was very familiar in those culture. But now people are living longer, and the risk of developing dementia is age. So the older they are getting in those society, the more they're seeing people that we all now have someone or know of someone who have dementia. So in my language, I don't know if there's any specific word for dementia.
Yeah, I think we last time we had a joint presentation, and we had one of our colleagues who, Professor Uduak, who has lots of experience with dementia, and her experience was that there wasn't. In actual fact, it's a sort of demonized if you have dementia because they think that you are dangerous, and there's discussions about witchcraft and things. And so she's been doing quite a lot of work to try and ease the burden of that in Southeast Nigeria. Dr. Nima, sorry, I didn't forget your question. This is a question from Dr. Nima that says, at what point would you recommend a dementia patient is placed in a memory home?
Well, that is a very difficult one. And like I said, we try and support people. There are gadgets out there to support. It's only when the risk becomes significant and that the risk to the person outweigh the benefit of staying in their own home. For example, if they're going out, we've had about patients who go out at 2 a.m., not appropriately dressed. During the winter month, that becomes dangerous. I've had patients who will forget to turn the cooker on and they won't even know what the fire alarm is for. Sometimes what the family do, they just cut off the gas supply to eat, so they don't have to cook, they have food delivered to them. So those are very personal decisions, and it will vary from family to family and also depend on how much support each family can provide. But we always say there is that room for respite care, because it's like being on a plane. They will always say, put on your face mask before that of your child. So you, the carer, we need that time to rest. You will need that time to recharge. You will need to look after yourself. So it depends on how much care you can realistically provide, how much support you can provide for your loved one to be safe in their own home. But the best advice is to keep them in their own home for as long and as safe as possible.
Are there any things you can do to prevent dementia?
Well, it's the age is the biggest risk factor, like I said. So except you don't get old, if you're getting old, your risk increases. But there are things, especially cardiovascular risk, that we can reduce. And we say midlife So they've done research in the past, which have shown that when you reduce some of those things like high blood pressure, diabetes in midlife, and live a healthy lifestyle, your risk of developing dementia is less compared to the people who didn't. So this age, in your 40s, in your 30s, in your 50s, that's where you need to pay attention to those little details: your blood pressure, your blood sugar, your lifestyle, keeping a healthy lifestyle, having a balanced diet. Those are the things you need to start putting in place to reduce the risk of developing it in future.
Thank you, Mercy. That's fascinating. We've had lots of comments about the fact that they liked your talk because it was really clear and well structured. So thank you for that.
Thank you.
Can I ask a question, please?
Oh, sorry. Who is that?
My name is Mercy.
Okay. Sorry, I didn't see your hand up. Please go ahead.
I don't know. I've been trying to look for where to put my hand up. My phone is not responding. So you've talked about your lifestyle, your sugar level, your BP, and the rest of them. Well, like I worked with patients who had dementia, and one thing I found out with most of them was that they had a kind of traumatic, they had relationships that was lacking trust, and they didn't trust the people around them. That was most of the issues I saw with them, because when their family members are around them, they don't talk. But once they go away, they want to tell you things. And when they try to say those things when their family members are around, they kind of shut them down. So in looking at dementia, because if you talk about your blood pressure, sugar, your lifestyle, where is the place of trauma in relationship with your family or spouse, or bullying? What part does it have in dementia? Because I tend to see that most of the people I work with who had dementia, most of them were those who never, they were not happy people. So where does the place of joy come in when it comes to dementia? But those people, I worked with elderly people, there were some people like in their 90s, 100, but because they were very happy people, their memory loss, the progression was so slow. But those ones that had anger issue, you just see them, they lose it completely. So where is the place of your temperament and trauma and trusting relationship around people and the effect in their old age?
Okay. Oh, sorry. Earlier, I did mention depression as a risk factor, that depression in midlife is a risk factor. So some of those things you're referring to as trauma and trust issue, they might have affected people's mood, and they probably suffered from untreated depression at some point, because depression is one of the risk factors I did mention earlier as a risk factor, depression in midlife, of developing dementia in later life.
Thank you. I think we've got 3 minutes more. I can see one more hand up. And whilst we're listening to that next question, can you, if you're here, please could you do the feedback? Because it's really important for us to get feedback on how we're doing. So there is a link. So if you can start doing the feedback. So Ngozi, please, can you ask your question?
Yeah, thanks, Dr. Ngozi. I just wanted to make a comment on what the doctor mentioned about care and support for people who have dementia. My mom had dementia, and sadly she passed away in 2019. So we all tried as much as possible to keep her comfortable, but I was here in the UK and she was back in Nigeria, and what she loved most was she had a shop, and what we did for her was to make sure she was in the environment that she loved, and supported her as much as possible, even in the shop, giving her a day bed, and she still saw her customers. She was really happy. And then when it was really bad and she was back at home, just making sure she had the right people around her, the music she loved, as much as possible, because we kept hoping she'll get better. But now that you've mentioned that dementia is not, you can't cure it. So we realized that, and we just made sure that we made her comfortable as much as possible. So I just wanted to chip that in for people who may not have their parents with them when they're suffering dementia. Just do your best to keep them as comfortable as possible and give them the things that make them happy. Thank you.
Well, thank you very much for sharing your story. And I think that's a wonderful note to end on. I think you'll be back, Mercy, because I don't think we'll be able to get through all the questions. We will share the slides for those of you that have asked for that. And I look forward to welcoming you back to another session, because I think this has generated lots of discussion. But thank you so much for a really interesting topic. So I'm going to hand you over to back to the CAHN team, and thank you once again.
Thank you.
That's great, thank you. Thank you, Dr. Mercy. That was a very informative session, fantastic information on a topic that can affect any of us, really, our family, our friends, you know, so not to be taken lightly. And, you know, brilliant, great discussions, great information, you know, so thank you very much. It's appreciated. Look forward to seeing you again. And thank you to our fantastic host, Dr. Ngozi. Thanks again. And thank you to all of our attendees on Zoom, Facebook and YouTube. And if you would like to access today's Health Hour session, as mentioned by Dr. Ngozi, you will be able to you know, access it on YouTube, along with other sessions if you've missed any, and also via email as well. Nicole has put the email address in the link in the chat box. Please do complete the evaluation link, as Dr. Ngozi mentioned also, because we would love to receive your feedback and your ideas. You know, and that link is in the chat box too. So now I'm just going to share some of our upcoming events with you. So please do put them in your diary and share them with your family and friends. And Lande is going to share the slides for me, please. That's fantastic. Brilliant. So our CATHIP Health Hour is back again next week. You know, so we do want you to join us, and the topic will be looking after your kidneys. And our guest speaker will be Professor Ibi Erikasima. So that's next Saturday, which is the 12th of November. And again, it's 11 till 12:15 p.m. And to register for the event, please email events@cahn.org.uk. Next slide, please, Lande. Fantastic, lovely. And do join us for another Healthy Heart session. If you haven't attended one, do please attend the great sessions, and you can learn about nutrition and how it affects our health. And Tuesday's session, which will be the 8th of November, 6 till 7:30 p.m. The topic is diet and detoxification, and it will be a registered nutritionist, Damiola, that will be doing the session, hosted by Dr. Ibar, who is again also a registered nutritionist. So again, to register for this session, do email events@cahn.org.uk. And also don't forget that during these tough times, you are not alone. If you do need any support, please do contact our service. Also regarding domestic or sexual abuse or suicide, or if you need any family and advocacy support, you know, do contact us on 077 10 022 382 for culturally and religiously appropriate specialist service, specifically for the Caribbean and African community. And you know, you'll be and it's delivered by our Black professional counsellors. So please do get in touch, or you can email help@cahn.org.uk. Next slide, please. Fantastic. And a special thank you to our CATHIP partners, you know, and do contact the service in your area if you need any further information. So it's CAHN is the first partner, and next is Black Health Initiative as well. Also Croydon BME Forum and Enfield Caribbean Association. The Royal Assembly Redeemed Christian Church of God, and also RAFA International Development Agency. So thanks again to our fabulous guest speaker, Dr. Mercy, and also to our fantastic host, Dr. Ngozi. And thanks to everyone for joining us today. So do enjoy the rest of your day, Do take care and look forward to seeing you again next week. Okay, thanks everybody and goodbye. Bye-bye.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics that include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.